MRCEM OSCE course, preparatory for the Royal College of Emergency Medicine, UK OSCE exam. Website www.mrcemoscecourse.com. Facebook page MRCEM OSCE course.
Hello folks, this is Muhammad Abdulghani Siddiq, co-founder and instructor of MRCEM OSCE course. Today I would like to discuss commonly appearing station in the MRCEM OSCE exam. This is nerve block station. Usually in every MRCEM exam there is at least 1, 2 or sometimes 3 stations regarding nerve block and local anesthesia, and you should be familiar and happy in how to approach such a station. Usually it will be teaching station, so once you read the scenario from outside the examination room and you review the pie chart, the task will be clear that you should teach a medical student or junior doctor about a specific nerve block, and you have 7 minutes to perform this task. So once you get inside the examination room, introduce yourself generally. For example, I am Dr. Muhammad, emergency physician. Meanwhile, wash your hands and have a look inside the examination room for any clues. Then proceed to the junior doctor, introduce yourself, confirm his identity and his level. Then ask him what does he want to know today. He will tell you, for example, that he would like to know about femoral nerve block, for instance. So ask him how much does he know about that specific nerve block, and then tell him that you are going to teach him today some important points about it. Invite him for any questions at any time, and tell him that at the end you are going to give him some lectures and online resources for further studying, and also you will be happy to meet him again for further discussion. Then if there is a patient, proceed to the patient. Usually in this station there will not be real patient, but usually there is a mannequin, or sometimes even there is no mannequin, but you are going to demonstrate to your junior colleague how you will perform the procedure. So let us now make agreement on the general approach to this station, because it might seem simple station, and surprisingly, in the feedback, you might find that you score very low. Why? Because you don't have systematic approach. So the key here is to have a systematic approach to this station. Let me first give you some stations that appeared in the previous MRCEM OSCE exams. Previously appeared femoral nerve block, fascia iliaca block, field block, hematoma block, facial block. Facial block, I mean supraorbital, supratrochlear, infraorbital, and mental nerves. We are going to discuss them later, okay? Also, ear block. There is also digital block, commonly appearing station, wrist block, and ankle block. So all of those appeared in the previous MRCEM OSCE exams. So my general theme that I will put in my mind when discussing with my junior colleague that I should speak about, I have 7 points in my mind. First, I will discuss with him the indications for the specific nerve block. Then I will speak about contraindications, then complications, and then the treatment of complications if took place. Then I will discuss with him my preparation for the procedure, and then I will explain to him the procedure itself. And finally, we are going to discuss the post-procedure care. And the marking sheet, which will be with the examiner, all the marks will be distributed between these 7 points. So it's not a matter of just explaining to your colleague how you will insert a needle and give the local anesthetic, but it's a systematic approach, and every single point from those 7 will be calculated and scored for you. The good news that most of these 7 points, they share common elements. Let me explain more. Indications, I'm going to discuss the indications for every single nerve block when I will speak about it. Contraindications, local anesthetic, there is contraindications. For example, to apply local anesthetic, for example, if the patient has allergy from local anesthetic. Other contraindications, if the patient has bleeding tendency or using blood thinning medications like warfarin, this could be relative contraindication. Also, patient refusal. If the patient refused the procedure, then there is no way to perform the procedure. Of course, unless there is issue about his mental capacity. But generally, patient refusal is contraindication to perform the nerve block. Also, if there is infection at the site of proposed injection, because this might transmit the bacteria to inside the circulation and causing septicemia. And also, if you are performing long or deep nerve block, for example, femoral or fascia iliaca, then if there is any possibility that this patient might have compartment syndrome, then nerve block is contraindicated because this might lead to mask the symptoms and signs of compartment, and subsequently the patient might lose his limb. Then let's discuss the complications. Also, we have common complications you can apply for any nerve block in the exam. We can divide the complications into local and systemic complications. Local complications, patient might develop severe pain because of the injection technique. Also might develop hematoma, bleeding, and sometimes injuries to the soft tissue, to the nerves or tendons. And later on, patient might develop infection. This is the local complications. Systemic complications, patient might develop allergic reaction or anaphylactic reaction. Also, patient might develop local anesthetic toxicity. And local anesthetic toxicity might happen because of inadvertent intravascular injection, or the other cause, if you give large dose that is more than the maximum dose. So it will be absorbed from the tissues and eventually it will go to the systemic circulation and cause local anesthetic toxicity. Sometimes patients might develop methemoglobinemia. Basically, all local anesthetics could cause methemoglobinemia, but particularly Prilucaine is the most commonly known agent that might predispose to methemoglobinemia. If happened, then the treatment is intravenous methylene blue 1 milligram per kilogram. Now let's discuss the treatment of complications. If the patient developed bleeding or any local complication, then stop the injection immediately and try to control if there is bleeding or try to control it. If the patient developed allergic reaction, then stop the injection and treat the patient by ABCDE approach, following the advanced life support in the setting of allergic reaction or local anesthetic toxicity. Follow the ALS protocol. If the patient went to peri-arrest or cardiac arrest, then consider giving lipid emulsion 20% in a dose of 1.5 ml per kilogram IV bolus, followed by 15 ml per kilogram per hour. And the IV bolus dose can be repeated every 3 to 5 minutes. Then let us speak about preparation. Preparation, you need to have consent, either verbal or written consent from the patient. Assess the patient's vital signs. Make sure that his vital is stable. Put him in a monitored area. Make sure about the required staffing. And calculate the local anesthetic dose. The local anesthetic doses, we have lidocaine, which is short-acting local anesthetic. Also, we have bupivacaine and prilocaine. Regarding the dose of lidocaine, it should be 3 milligram per kilogram maximum dose, or 7 milligram per kilogram if mixed with adrenaline. Regarding bupivacaine, the dose is 2 milligram per kilogram with or without adrenaline, and bupivacaine is long-acting. Also, we have prilocaine. The dose is 6 milligram per kilogram or 8 with adrenaline. So after calculating the maximum doses of local anesthetics, then also part of the preparation that find the landmarks for your procedure, and please make sure that there is IV line, there is IV cannula in large peripheral vein. By the way, don't perform any procedure, never ever, without IV line in place. You must mention before any procedure that you need IV line in place. In case any complication happened, you will be ready to give medications. Then clean the area. Before that, please wear your personal protective equipments, gown, goggles, and gloves. Then clean the area using chlorhexidine or povidone iodine. You might also consider using ultrasound to perform the procedure, either ultrasound assisted or ultrasound guided procedure. Then now we finished the preparations. I will repeat briefly the points of preparation. You need to have consent, check vital signs, put the patient in monitored area, prepare your staffing, wear or don your personal protective equipments, prepare the local anesthetic dose, and also define the landmarks for your procedure, put IV cannula, clean the area, and consider using ultrasound. Then after that, speak about the procedure itself, how you will perform it, and finally, speak about post-procedure care. Post-procedure care means that after giving the local anesthetic, you need to assess the patient again, make sure he is vitally stable, and keep him in a monitored area, and make sure that your local anesthetic took place. Usually, the short-acting local anesthetic like lidocaine, its action will begin after about 5 minutes. But for the long-acting like bupivacaine, this might take 20 to 30 minutes to start. Okay? Then in the post-procedure care, don't forget to mention the aim of why you perform the nerve block. For example, if patient has hematoma block, then mention you are going to reduce, or your colleague from orthopedic team will reduce the fracture, this radial fracture, for example, and you are going to apply cast. If femoral nerve or fascia iliaca block, then mention traction to the fracture shaft of femur. Okay, so don't forget the main aim, that why you give the patient the local anesthetic. If you need to suture, for example, or to drain arches, mention that, all this in the post-procedure care. Now I'm going to discuss with you the indications for every specific nerve block, and if there is any important point regarding it. We'll start by femoral nerve. Femoral nerve block is indicated for any procedure that in the knee joint, or if the patient has fracture shaft of femur, and also it might be beneficial in fracture neck of femur. The landmarks for the femoral nerve block, that is imaginary line between the anterior superior iliac spine and pubic tubercle. In the midpoint, just move caudally 1 to 2 centimeters and palpate the femoral artery pulsation, and then your point will be 1 centimeters lateral to the femoral artery pulsation. Remember that you have the femoral nerve from medial to lateral, you have the femoral vein, then femoral artery, and the most lateral is the femoral nerve. So 1 centimeters below the inguinal ligament, midpoint of inguinal ligament, and 1 centimeter lateral to the femoral artery pulsation. Here you will inject about 20 to 30 ml of local anesthetic. Usually, but don't please exceed the maximum recommended dose. And usually here we might use mixture of lidocaine and bupivacaine. So you need quick action and also uh, long duration of action. Once you inject your local anesthetic, please inject slowly, and after every 5 ml, stop and aspirate to make sure that you are not accidentally inject into the circulation. This is femoral nerve block landmarks. And regarding the contraindications, as we mentioned, I'm not going to repeat because I gave you all the general theme for the contraindications, complications, and treatment of complications. The preparation, don't forget in preparation for femoral nerve block to use ultrasound, or at least mention that it will be 1 point, will be scored for you. And the post-procedure care, if the patient needs traction, for example, for femoral shaft fracture, it can be done after that, and patient should be in a monitored area. Now let us speak about fascia iliaca block. And the fascia iliaca, the landmark for fascia iliaca, or let us first speak about indications. Fascia iliaca block is beneficial for fracture neck of femur, also shaft of femur, and also for any procedure in the knee joint. And the good point that fascia iliaca block will anesthetize along with the femoral nerve. It will anesthetize the lateral femoral cutaneous nerve, the lateral femoral cutaneous nerve of the thigh. So the lateral part of the thigh will be anesthetized as well. And also, it might cause anesthesia for the obturator nerve. So it will perform triple block: femoral nerve, lateral cutaneous nerve of the thigh, and obturator nerve. The landmark for fascia iliaca block: if you draw an imaginary line from the anterior superior iliac spine to the pubic tubercle, the junction between the lateral third and the medial 2/3, just go down 1 to 2 centimeters, and this is the area of injection. Use ultrasound, please, assisted or guided. Then, when first, of course, after all the preparation we mentioned earlier in this podcast, then when you insert your needle, you might hear 2 pops. One when you pierce the fascia lata, and the other pop when you pierce the fascia iliaca. And here you will be inside the fascia iliaca compartment where you can give your local anesthetic. Now let us speak about field block. Field block is commonly appearing station in the exam. It is really simple, and usually the scenario will be of a patient has back abscess. So the idea is really simple. You will give your local anesthetic in circular movement around the abscess area. Make sure that you don't inject inside the infected skin area or inside the abscess, because the infected area has high acidity and it might lead to local anesthetic toxicity. And also, the effect of local anesthesia will be very weak. So make sure that you make circular field block around the abscess in the intact skin. The indication is clear to for abscess drainage. For example, also if you would like to suture laceration that is maybe irregular and you need to perform field block. Let us discuss hematoma block. Hematoma block is commonly appearing, and usually they will give you a hand inside the station. Your junior colleague will give you a hand to demonstrate for him. So first, as we agreed, speak about the indications. Indication for hematoma block is distal radial fractures, like for example, Colles fracture reduction. Then the same contraindications, complication, and how to treat the complication, and also the same preparation. If there is any X-ray inside your station, please make sure that you review it even prior to introducing yourself to your junior doctor. This is important point. If there is any note inside the station, please go and see that notes, and after that, proceed to your patient or your junior colleague if there is teaching station. In hematoma block, usually there will be an X-ray of a patient with displaced distal radial fracture. So go assess the notes, then proceed to your junior colleague. Also, you might see inside that room a bottle of local anesthetic, lidocaine. So please check the expiry date because usually it will be expired. And before checking the expiry date, during the preparation time, tell your junior doctor that he should make sure about the expiry date of the local anesthetic when you speak about it. Also, regarding hematoma block, the landmark, usually it will be performed in the dorsum of the wrist at the site of the hematoma that is formed by the distal radial fracture. So you will enter proximal, about 1 centimeter proximal to the hematoma site, to the fracture site, and direct your needle 45 degrees to be between the two broken pieces. In this area, and you might consider using ultrasound to assist you for this procedure. Once you are between the two broken bones or the two pieces, then aspirate. You should see blood in your syringe. This confirms that you are inside the hematoma, and now you can inject your local anesthetic. Please make sure that you use the IV formulation of lidocaine, because in hematoma block, your local anesthetic might also go to the systemic circulation through the bone marrow, and it might cause toxicity. So make sure that you are using the IV formulation of lidocaine. After the procedure, in the post-procedure care, try to reduce the fracture. Also do X-ray to confirm the reduction, and also apply cast and put a patient in a monitored area. Make sure that you mention all these points to your junior colleague in the post-procedure care for hematoma block. Now let us move to facial block. We have 4 nerves in the face. We have the supraorbital, supratrochlear, infraorbital, and mental nerves. So regarding the supraorbital and supratrochlear nerves, those 2 nerves supply the forehead. So the supraorbital nerve, it emerges from the supraorbital foramen, and this lies in, just above the superior orbital rim, in the area of the eyebrow. You can the supraorbital foramen, you can feel it 25 millimeter from the facial midline, 25 millimeter lateral to the face midline. This in the mid-pupillary line. What is the mid-pupillary line? This is imaginary line that cross through the pupil and the corner of the mouth. This is the imaginary mid-pupillary line where you can feel the supraorbital foramen. In fact, also the infraorbital foramen and mental foramen, all of them lie at the same line, in the mid-pupillary line, which lies 25 millimeters from the face midline. So we have the supratrochlear nerve. Also, it emerges from the upper medial corner of the orbit. The supraorbital and supratrochlear supplies, or both of them supply, the ipsilateral side of the forehead. So you can perform block for both of them. We have many approaches: lateral approach or medial approach. I will discuss with you the medial approach, or what we call the eyebrow block. From the midline at the level of the upper border of the eyebrow, inject from subcutaneous infiltration from the midline and until the point of the supraorbital foramen. Infiltrate about 3 to 5 ml of your local anesthetic, but don't exceed the maximum recommended dose. Please avoid injecting into the supraorbital foramen directly, because the local anesthetic might even go through the foramen to the eye and causing temporary blindness because of anesthesia to the optic nerve. So try avoiding injecting inside the supraorbital foramen. So now we'll speak about the infraorbital nerve. Infraorbital nerve, this leaves the skull through the infraorbital foramen, and it lies about 1 centimeter below the inferior orbital rim to 25 millimeter lateral to the facial midline, exactly at the mid-pupillary line. You can right now feel it by your finger. The infraorbital nerve supplies the lower eyelid, the medial aspect of the cheek, and the lateral part of the nose, and also the upper lip. You can anesthetize it either by intraoral approach or directly through the skin from outside. I will speak about the transcutaneous extraoral approach. First, define the infraorbital knot foramen. Then, from below, you can insert your needle about half centimeter below the infraorbital foramen and direct your needle posteriorly and superiorly until you reach just near the infraorbital foramen until you contact the bone, and then withdraw your needle 1 to 2 millimeter and inject around the infraorbital foramen. Please also avoid injecting inside the infraorbital foramen. Now let us speak about the mental nerve. Mental nerve also emerge from the mental foramen, which lies 25 millimeter from the facial midline in the mid-pupillary line, and this is about 1 centimeter above the inferior margin of the mandible. There is inferior and posterior approaches. I will describe the posterior approach. Before the approach, the mental nerve supplies the chin, the ipsilateral chin, and also the lower lip. So the lateral approach, you come from the behind or posterior to the mental foramen, from the side, from the cheek, and then enter about half centimeter and direct your needle towards anteriorly and posteriorly until you contact the bone near the mental foramen, then withdraw about 1 to 2 millimeter and inject your local anesthetic around the mental foramen. This is the mental nerve. Now let's speak about ear block, and this station appeared several times in the MRCEM OSCE exam. Ear block, we have two techniques or two approaches. The circular field block, where you will give your local anesthetic all around the ear, or you can anesthetize the 3 nerves that supply the ear. And this is what we prefer that you should describe in your exam. So inform your junior colleague that ear block is done. Indication for ear block if there is any procedure in the ear, like laceration, suturing, abscess drainage, or any surgery. You need to anesthetize the greater auricular nerve, the lesser occipital nerve, and auriculotemporal nerve. The greater auricular nerve anesthesia is done by injecting subcutaneous infiltration about 1 centimeter below the earlobe, horizontally in this area, just to block the greater auricular nerve. Then immediately behind the ear, you can also perform local infiltration to anesthetize the lesser occipital nerve. Then auriculotemporal nerve anesthesia, and this can be achieved by subcutaneous infiltration about 1 centimeter anterior to the tragus. Now let us move to digital nerve block. Digital nerve block is really useful in any procedure in the fingers or toes. So if we discuss the digital nerve block, usually in the exam it will come in a finger. Speak about indication. So any procedure in the fingers like fracture reduction, dislocation reduction as well. If there is abscess needs drainage or laceration needs suturing. For example, contraindication, the general contraindication as we discussed, and the same complication and treatment of complication, the same preparation. Here, in the preparation, avoid using adrenaline in addition to the local anesthetic, because theoretically it might lead to ischemia, necrosis, and loss of the digit. Also, theoretically, the use of adrenaline should be avoided. Also, if there is any procedure in the tip of the nose, in the ear loop, or in the penis. The landmarks, we have two pairs of nerves. We have the two volar and two dorsal digital nerves. Two volar and two dorsal digital nerves. We should anesthetize all of them. Worth mentioning, the volar digital nerves or the anterior digital nerves. These nerves supply the volar aspect of the fingers and also the nail bed of the middle three fingers. I mean the index, middle, and ring fingers. So any procedure in the nail bed of the middle three fingers, you can only perform volar nerve, digital nerve block. But the nail bed of the thumb and little fingers is supplied by the dorsal digital nerves. Regarding the dorsal digital nerves, they supply the dorsum of the fingers and, as I mentioned, supply the nail bed. The dorsal digital nerve supplies the nail bed of the thumb and little fingers. So I hope this is clear. So we have many approaches. We have the volar approach, we have the dorsal approach. Also, we have the metacarpal block. But I will describe now the dorsal approach from the posterior aspect of the finger. Here, you should give two injections. The dorsal digital nerves, you can find them at 2 and 10 o'clock, and the volar digital nerves at 4 and 8 o'clock. Another landmark for the volar digital nerves or anterior digital nerves, they pass along the imaginary line that connecting the finger creases at the margin of the finger creases, skin creases. Here you can find the volar digital nerves. So from the dorsal approach at 2 and 10 o'clock, the pair of dorsal digital nerves, and at 4 and 8 o'clock for the palmar digital nerves. So inject from the posterior approach or dorsal approach because it is less painful and the skin here is thin. Insert at 2 o'clock. Immediately you will encounter the bone. Just withdraw your needle 1 to 2 millimeter and inject about 1 ml of your local anesthetic, usually lidocaine. Then don't remove the needle, but pass it anteriorly until you reach or you contact the skin at the volar aspect. This about at 4 o'clock. Don't pierce the skin, but stop there, and you can inject another 1 ml of local anesthetic. Now remove your needle, and in the other side, do the same. Wait about 5 minutes. The anesthesia should take place at this time, and start your procedure. This is digital block. Now let's move to speak about wrist block. We have 3 nerves to block in wrist block. We have the medial nerve, ulnar nerve, and radial nerve. The indication for wrist block: any procedure in the hand, for example, suturing, lacerations, abscess drainage, fracture reduction, or dislocation manipulation. Regarding the medial nerve block, you should first identify the landmarks for the medial nerve. It lies in the volar aspect of the wrist, between the tendons of flexor carpi radialis and palmaris longus. Put in mind that palmaris longus is absent in about 10 to 15% of the population. But generally, you should give deep injection between the 2 tendons of flexor carpi radialis and palmaris longus at the level of the proximal wrist crease. Insert your needle deep, about 1 centimeter deep, and then inject about 5 ml of your local anesthetic. Also, if you would like to anesthetize the superficial branch, when you bring your needle out, just before taking out, you can make subcutaneous infiltration at the same area, so you will anesthetize the superficial branch. Regarding ulnar nerve, there is also many approaches. I will describe the medial approach, where the ulnar nerve lies behind the flexor carpi ulnaris tendon, between the tendon and between the ulnar artery. So take care not to inject inside the ulnar artery. The medial approach, you will come from medial aspect and insert your needle directly below the flexor carpi ulnaris tendon. Then aspirate to make sure that you are not inside the ulnar artery, and inject about 5 ml of your local anesthetic. Also here you can give, before leaving, if you would like to anesthetize the superficial branch, which give sensation to the hypothenor area, give superficial injection before bringing your needle out. You can give superficial injection as well. Regarding the radial nerve, palpate the radial pulse, and at the level just proximal to the radial styloid, you can give subcutaneous infiltration. Start from lateral to the radial pulse and along all the area until the area of the distal radioulnar joint over the dorsum of the wrist. Subcutaneous injection from lateral to the radial artery pulsation until the distal radioulnar joint posteriorly over the wrist. This is the wrist block. Finally, I will speak about ankle block. Again, recently it is frequently appearing in the exam. Ankle block, we have 5 nerves to block. 2 by deep injection and 3 by superficial injection. We have deep peroneal nerve, superficial peroneal nerve, sural nerve, tibial nerve, and saphenous nerve. The 2 deep injections will be for the deep peroneal nerve and also for the tibial nerve, whereas the superficial injection will be for the remaining. Indication: any procedure in the foot, contraindications, the same common contraindication, same complication and treatment of complication, the same preparation as we mentioned before. Now let us speak about the landmarks. The deep peroneal nerve supplies the first web space over the dorsum of the foot. This lies between the lateral aspect of the big toe and medial aspect of the second toe, the first web space posteriorly. And you can locate the site of injection at the anterior aspect of the ankle joint, anterior aspect of the ankle joint, between the tendons of flexor hallucis longus and tibialis anterior. If you would like to feel the flexor, the extensor, it is not flexor, extensor hallucis longus. If you would like to feel the extensor hallucis longus, you can make extension to the big toe. It will stand out. It lies lateral to the tibialis anterior tendon. So between the 2 tendons, the deep peroneal nerve lies just behind the extensor hallucis longus. Inject between the 2 tendons, aiming to the behind laterally to anesthetize the deep peroneal nerve. Give about 3 to 5 ml of your local anesthetic. Regarding the superficial peroneal nerve gives sensation to the whole dorsum of the foot, except the first web space. Injection will be lateral to subcutaneous infiltration, lateral to extensor hallucis longus, all the way until the lateral malleolus. Now let's speak about sural nerve. Sural nerve supplies the heel of the sole, and the injection will be just posterior to the lateral malleolus until the Achilles tendon, subcutaneous infiltration. Now let's speak about the tibial nerve, and this is deep injection between the medial malleolus and the Achilles tendon. Palpate the posterior tibial artery pulsation, and then give deep injection about 1 centimeter lateral or posterior to the posterior tibial artery pulsation. Give deep injection about 5 ml of local anesthetic. Here you will anesthetize the tibial nerve. Tibial nerve divides into medial and lateral plantar nerves, and those supply the anterior half of the sole. Tibial nerve branches into medial and lateral plantar nerves, and both of them supply the anterior half of the sole. The last one is the saphenous nerve, and this runs along the saphenous vein. That is, with regard to the medial malleolus, it lies just proximal and anterior, about 1 to 2 centimeter proximal and 1 to 2 centimeter anterior to the medial malleolus. And this you should apply superficial infiltration. The saphenous nerve gives sensation to the medial aspect of the ankle joint. So by now we cover all the nerve blocks that appeared in the previous MRCEM OSCE exam. Important advice: you have only 7 minutes. You don't have 2 hours to speak about the nerve and you would like to mention everything. Please put in your mind that if we would like to mention everything related to any specific nerve block, we might need days. But during your exam, you have only 7 minutes. So please don't take your time. Just try to be quick and control the rhythm and the pace, so you will finish before the time. So quickly get inside the room, wash your hand, introduce yourself, confirm the general doctor and what he wants to know today, and invite him for the conversation, and tell him that today you will speak about, for example, the ankle block. Tell him that you will speak about the indications. What is the indications? Quickly. Okay. Then contraindications. Give him 2 or 3 contraindications. Then move and mention the complication. Tell him we have systemic and local complications. Mention 2 or 3 from each. And treatment. Tell him to stop the injection. Make sure you inform him about intralipid if needed, if the patient is peri-arrest or arrest. But the main treatment for complication is supportive and following the ALS protocol. Then move to the preparation and mention the preparations. This is really important. Okay? Then immediately speak about the procedure itself and quickly jump to the post-procedure care. You have 7 minutes. I know that the most common cause for failure in this station that you cannot finish within 7 minutes. Take care about this point, please. And even you can practice with a colleague or even with yourself with 7 minutes counting for you to make sure that you finish in the this specific time frame. Good luck. Thank you.